When you get assigned to a study, you just know that these are the documents that need to be filed in the ISF and in the eTMF. And you don't really know why. You just know that you have to. And then you slowly understand then all these requirements that we have in clinical trials come because of regulation. And we need to comply with it. And we need to have these documents properly filed because of regulation. It's section 8. And it categorizes these documents in 3 main sections: documents that are generated before the trial conduct, documents that are generated during the conduct, so operations, and then those that are generated at the end of the conduct. Usually I think of these documents as being crucial because they prove 3 things. They prove that the site personnel is qualified and they are acting and conducting the trial according to regulation and the protocol. That's the proof that we have, right? CVs, GCP certificates, the software tools certificates that we do, the protocol signature pages, the proof that you are complying with the protocol and regulation. It also proves the CRA's activity. You're going to do monitoring visits and you're going to do reports and you're going to write follow-up letters. And all of these documents will also be filed in the essential documents. So it's also a proof of your work as the CRA. And then, of course, the third element that it proves is
Daily enthusiasts, today we're talking about the role of the CRA in the trial master file. If you're an eTMF specialist or a clinical trial assistant, you will be working with CRAs. In this episode, we will learn about essential documents at an SIV. We'll learn what the CRA looks for on the Delegation of Authority log and 6 steps that are involved at a monitoring visit. And the guest I have today, Maria Alexander Milas. She holds a master's degree in clinical trial monitoring and is a certified clinical research professional with clinical operations experience spanning both at the CRO and sponsor. Maria has built the CRA Connect, which is an online community that supports CRAs through a safe networking space and has ongoing educational content. Maria, welcome to the TMF Daily podcast.
Thank you. Thank you, Nicole, for having me.
So we have so much to talk about today. And I love getting insights from CRAs because there's such a wealth of knowledge, and I'm pumped for this interview. So just to kick it off, can you give us like a super high level overview of your clinical research journey and how you ended up where you are today?
Sure. So I started, I would say, from a little bit of atypical background. Although the industry is changing, so we are accepting more and more CRAs with a background that does not come from a scientific or biological background, but I came from studying linguistics. So I always had a very huge curiosity about research and innovation and healthcare. So I specialized in biomedical and pharmaceutical translation, translating all the documents that we are going to talk about from English into Spanish at the time, which was my local language. I still wanted to be closer to research and closer to innovation. So at one point, the director of the master that I was doing at that time told me just one sentence: look into clinical trials. And that, was a little bit of opaque sentence. It didn't say much. I didn't understand what that meant, but it opened the door. And because I was such a curious person, I said, what does he mean by that? So that's how I learned about all these roles that you have in clinical research operations. And I started with the clinical trial assistant role at a huge CRO. And then because I didn't come from a very scientific background, again, I said, well, what do I need to transition into the CRA role? Because the closer I was to the CRA role, the more I saw that I wanted to be a CRA. At that time, my manager said, well, while you get some experience by being a CTA, a trial assistant, why don't you also get some certifications? And I took another master's degree in clinical trial monitoring. And after a year, I shifted into the CRA position. And I started by monitoring observational trials, which I think it's a very common and a very standard way for CRAs to be introduced to monitoring clinical trials. And then, that's how the journey started. And I was a CRA for around 5 years. And after that, only around 3 years ago, I switched to the tech side, to the tech industry as a clinical subject matter expert. And there I am still.
Wonderful. And what a fascinating story. Because you don't hear that every day of like how you get into clinical research, and it's never really a linear path.
Absolutely. I get this question, I promise you, absolutely every single day, more than once. How do I become a CRA? And I usually always need to answer, I wish there was one standard answer I can tell everybody, but there's not. And that's also the beauty of it.
Mm-hmm.
Because everybody has opportunities, of course, with some more effort or some more crossings in your roads, but everybody has the same opportunities to get into this industry.
Mm-hmm. And like you, I started off as a clinical trial assistant, which is a great role if you want to get to be that CRA, because it exposes you to so many different things in a clinical trial and different people that work in the industry. So it's
Absolutely.
such a good role. All right, let's go over essential documents. We'll just start at like an SIV, for example, the site initiation visit. And we often emphasize the significance of essential documents, particularly stressing like their proper collection and filing for clinical research associates. Yet, it begs the question like, where do these documents originate and what exactly do these documents entail?
It's a very good question because we as CRAs, we're not told that either. You know, when when you get assigned to a study, you just know that these are the documents that need to be filed in the ISF and in the eTMF. And you don't really know why. You just know that you have to. The more experience you get, the more you know, and the more you know about regulation as well. And then you slowly understand that all these requirements that we have in clinical trials come because of regulation. And we need to comply with it. And we need to have these documents properly filed because of regulation. And actually, these essential documents are mentioned in the ICH GCP. And ICH GCP dedicates a full section to the essential document. It's the last section, I think it's section 8, and it categorizes these documents in 3 main sections: documents that are generated before the trial conduct, documents that are generated during the conduct, so operations, and then those that are generated at the end of the conduct. Usually, what I think of these documents as being crucial because they prove 3 things. They prove that the site personnel is qualified and they are acting and conducting the trial according to regulation and the protocol. That's the proof that we have, right? CVs, GCP certificates, the software tools certificates that we do, the protocol signature pages, the proof that you are complying with the protocol and regulation. It also proves the CRA's activity. You're going to do monitoring visits and you're going to do reports and you're going to write follow-up letters. And all of these documents will also be filed in the essential documents. So it's also a proof of your work as the CRA. And then, of course, the third element that it proves is that there's an agreement of all the parties that are involved in the clinical trial. There are agreements in place, there are insurance certificates, there's contracts in place that you need to have filed so that everybody not only protected and covered by it, but also as a proof that we all know what we've committed to from the very beginning.
Very good. That was a very good explanation and rundown of why they're so important. So let's go into like the delegation of authority log, or sometimes called the site signature sheet. And it's often acknowledges like the most significant document at the SIV, right?
Mm-hmm.
So can you walk us through that process of completing this document and how you ensure it remains up to date, given its dynamic nature?
Absolutely. We have several live documents that we call them in clinical trials, which is it's never finished. It's never complete until you close this document and you close the clinical trial, basically. So as you correctly said, we start and we open this document at the SIV because you hopefully have a meeting with all the site staff who will participate at the site in the clinical trial, and you will be able to meet with every single person. And the way that you confirm that the principal investigator confirms that this is the team is by adding their name, the date that they're starting their activity in the clinical trial, their signature, and the PI confirms also with her or his signature on the delegation log that these people are confirmed, that they're delegated to do those tasks. That's how it starts. It's a very manual process. Unless you have an electronic delegation of authority log, then things become a little bit easier, especially maybe, hopefully, you don't have the risk to lose this document, which at site happens so often. And we're in such big troubles when we lose a delegation of authority log. But it's a very manual process because a clinical trial can last months and years. And there's a lot of movement. The same way that we have CRAs coming and going from a clinical trial, the same happens with the sites as well. You can have a study nurse coming in, being the backup for another study nurse who maybe is on maternity leave, or maybe we just change the site staff that we have during the study. So you need to be informed as the CRA by the site that there's changes in the personnel, in the site staff. But many times it's not easy to keep up to date with these changes in the personnel, because imagine an oncology trial that has one principal investigator, but 9 sub-investigators, 3 study coordinators, 4 data entries. And it's very common that we forget to tell the CRA, oh, we had another sub-investigator coming in today. And what the CRA does is you're on a monitoring visit and you're monitoring the source data, the medical records, and you spot a name that you don't know. And you try to understand, well, who is this person? And then you figure out, okay, there must have been a change. There must be, let me check the delegation of authority log. Oh no, it's not up to date. Oh no, I don't have the CVs. I don't have the GCPs. yes, that's how important the delegation log is. And then you will basically just go to the principal investigator, try to have the confirmation that this new person has joined the study. It triggers a series of documents that you need to get from this person, the CV, the GCP, any other specific certificate, or sign all the documents that they haven't signed. But hopefully it is done in time and it is not done 2 months after this person did their first activity in the study, and it's done as soon as possible.
So let's back up a little bit. Because you just unpacked a lot right there. You mentioned, what happens? Delegation's lost. Can't find it. What do we do?
Yeah, it's very funny. Sometimes I believe in serendipity, because this is the exact question we had this morning in the CRA Connect community by a CRA who was traveling to the site, and she was just sent a text by the study coordinator that they can't find the delegation of authority log. And I can think of myself, and I had this situation twice while I was a CRA. And you just arrive on site and you want to check the delegation of authority log because you're trained that it's a document you need to check consistently. And it's just nowhere. It's not in the ISF. It's not in the principal investigators bind. It's nowhere. It's nowhere to be found. Yes, panic by everyone. So I've seen 2 solutions to this. One of them is, if we are diligent, we will always have a scanned copy, if it's paper delegation of authority log, in the eTMF, right? So in that case, in one of the 2 cases I had, we printed the delegation of authority log and we did a note to file explaining what happened, explaining that unfortunately site has lost it. We don't know who, but at site it was lost. And we are explaining that from now on, this will be considered as an original document. Now, Nicole, you as a specialist in the TMF, you will tell me now if we proceeded according to what is allowed or not. But that was one of the solutions. The second solution was, we were about to do the exact same thing, to print the scanned version we had from the delegation of authority log. But in the meantime, by the time that I went to site for the next monitoring visit, the delegation of authority log appeared out of nowhere. So that's great, because one less issue, but it is true that happens a lot. And sites still nowadays with a lot of paperwork. And not always they are very organized and they have all the paperwork per study, per sponsor, and each in a binder. So it's common that you just misplace papers and logs from one study to the other, because we know that these documents, they're required in all the clinical trials, but they all look the same. So it's easy to just put one log into the section, the proper section, the correct section of the binders of another study.
Now, another thing that kind of comes up is, say you've got a sub-investigator and they never filled out a financial disclosure form, okay? And we're doing our review. It comes up The sub investigators no longer working at the site, and we can't reach them.
Mm-hmm.
Now what?
I wish I had a good solution for that, but we unfortunately don't. The situation you just described is very common.
Mm-hmm.
And not just for financial disclosure, but for anything. Even if you find the CV online of some sub investigator you had a year ago, you still needed to have signed, dated with the initials of that person. So you can't, unfortunately, backtrack your work and catch up on the documentation you didn't get at that time. So unfortunately, I think we would just need to report it and create a note to file explaining what the situation was, and probably in an audit, both by the sponsor or the regulatory authorities, that would be a finding. But we did what we could, right?
You do the best that you can, and you just
Exactly.
document, right?
Yeah.
And
Yeah.
you do your due diligence, and you try and contact them any way that you possibly can, looking on the internet, contacting old places that they might have worked at, just so
Yeah.
you can get their contact information.
Yes, which is absolutely realistically almost impossible, because we know investigators and site staff are constantly being contacted by everyone. They're
Mhm.
and
Bombarded.
usually, yes, bombarded, and they try not to give their personal emails just because of that, because of trying to be avoiding a little bit this bombard of from sponsors, from vendors, from CRAs, from everybody. So they try to keep it limited to their institutional emails usually. But
Mhm.
once you've changed institution, now try to figure that out. We try all the combinations. We try name.surname at institution.com, institution.es, back in Spain, institution.net, whatever. But
Mhm.
many times it does not work.
No. Nope. But you got to document that you at least tried, and these were the steps that you did to try to do it.
Yep, absolutely.
All right, let's shift gears a little bit. You did a recent post on LinkedIn that really caught my eye, and you wrote 6 steps that involved a monitoring visit.
Mm-hmm.
And step 1 involved arriving at the site, you're settling in at your monitoring space. Could you elaborate on the importance of this initial step and how it sets the tone for the rest of the visit?
Of course. Well, every single monitoring visit is a new world. And especially when you go on site for the first time to a site, you never know what you're going to have. You don't know if you'll have a clean, bright, perfectly prepared room for monitoring activities, which sometimes happens, thankfully. Or you'll have a little corner in your principal investigator's desk. They just clean a little bit from paperwork, a little corner, and there's where you try to fit your laptop, and that's where you're going to work. Sometimes I've even had in the principal investigator's room, I was sitting at his desk in a little corner, and he was visiting patients. And at one point, he just runs a curtain between where I am, where he's seeing patients. And I was literally trying not to make noise by typing at my computer because he was seeing a patient just behind the curtain. So you never know what you're going to find. But how does that set your monitoring visit? Well, like any profession, if you have the tools, if you have the environment, if you have the light, brightness, if you have everything you need, you're probably setting yourself up for success. But if it's the opposite, it's just going to make it a lot harder for the CRA to focus, to spot to differences, to spot issues, to find papers. And if your physical space is limited to a corner of the principal investigator's desk, think of this, Nicole. Where am I going to put my laptop, my open binder of the investigator site file, the paperwork of the medical records, if they're paper based, the notes of the nurse, which probably are paper based as well, and if there's any lab kits or I need to do an accountability of the investigational drug, where does that fit? So you end up with having piles of documents on your lap, on your keyboard, then you're typing in weird words because they're typing on your keyboard. So it definitely can be challenging.
Mm-hmm. So you got to be flexible.
You know, I wanted to know what's the skill I need to work on. And I always say adaptability, because I promise you, you don't know what you'll encounter when you go on site. And even if it's a site you know because you've been there 20 times, it doesn't mean for sure, you're not guaranteed that tomorrow when you go on site, you'll go to the same room, you'll have the same time or the same space.
That's a very good point. In an industry where consistency is key, it's not always consistent at the site where you're going to be monitoring. It's wherever there's space.
Yep.
Sometimes it's designated, sometimes you're behind the curtain.
Yeah, I've heard much worse though.
Oh my goodness. Well, let's move on to step 2. You mentioned going straight to monitoring and reviewing various aspects. So what are some common action items or queries that CRAs are typically encountering during that monitoring visit?
When you go on site, you usually already have action items that you've opened at your previous monitoring visits. So most of the action items that you need to deal with are opened by yourself. So you know them by heart, you've prepared in advance, you even let your site know that you're going to try to close these action items. So those ones, let's say, we have them under control. We know which ones they are. Hopefully the solution is going to be today. We close them today. If not, next time, but they're in our control. Now, when it comes to queries though, it's the same thing. If you're the one who opened the queries, you'll see that you have the answers in the eTMF. You can close the query or you can re-query that query and you can ask more clarifications on that specific matter. But when it comes to queries, there's more parties that can open a query for your site. It can be the sponsor can open query, the data managers can open queries, the medical monitors, the coders, everybody can open queries to the sites. And of course, you are the one responsible. CRAs is responsible to close and clean the CRF. So even though if a query is opened by, let's say, the sponsor, somebody at the sponsor, the site responds, the CRA needs to close it and clean and confirm that it's responded. And sometimes that's not very clear because you see yourself, this is like a tennis match. You see the ball going from one side to the other and you're trying to understand what the conversation is, but not always you understand. And you also see where, especially when it comes to sites that are not English native speakers, and you can see that there's a difficulty in there as well, because the field in the eCRF is very limited to the amount of characters that you can write. So queries usually are very short, very direct, straight to the point, trying to make the most out of those, whatever number of characters we have. So I think that's the big difficulty when it comes to queries and action items. But the most common ones, I would say, you will always have queries on safety elements, such as the adverse events and serious adverse events, because you always want to double check, triple check, as many times check as you can that those actions that the site took on the safety matter, it was correct, it's precise, it matches also the IP accountability page, because usually we log the drug accountability on a different page in the eCRF, but it needs to match what you say that you've administered the patient for these adverse events. So I think in here, we can expect queries all the time, in all the patients and by everybody.
Is there a certain timeline for when queries have to get answered? At what point are we getting nervous because it's been open too long?
Nicole, we're nervous all the time. We do have timelines and we do have deadlines, and standardly we have queries being responded within 5 days, and it's more or less the same as entering the data. You have 5 days from when the patient visit occurred to enter the data. Each study has their SOP, so it might differ 1 day up, 1 day down, but it's around 5 days. But realistically, you will have sites that are very on top of their thing and they respond to the query in 20 minutes, and that's a miracle. And you think you hit the jackpot with this site. But then you have other sites who, instead of 5 days, it's 25 days. And sometimes sponsor needs to come in and push and remind the sites, and it requires a bit more work. But I think usually our sites are somewhere in the middle. Maybe not 20 minutes, but maybe not 25 days.
So step 3 emphasizes the importance of thorough note-taking. Can you share some tips for effective documenting your observations during a monitor visit?
This is a funny one because, Nicole, as you always say, if it's not documented, it did not exist. And I can't remind CRAs more of that. Document everything. Now, of course, don't document, let's say, some of the elements that are not relevant because we can't document, the simple things like the handwriting of the principal investigator is not good. It's not the relevant information that you need to have in your ISF or in your records for posterity. But when it comes to patient, when it comes to the conduct of the trial, when it comes to what you are observing, what are you finding, document everything. And it's very easy to say document everything, but when you're on site, what is everything and how much you document? Because if you need to split your time between monitoring data and not making notes of what you're monitoring, you're taking time from monitoring more data to take those notes. So I try to think that the success in a good note taking is the preparation for that visit, because you know what you will have to monitor, more or less. You know how many patients, you know what data, you know what activities, you know which visits, and you know which documents you have to review. So if you can create yourself a checklist for that visit, and every time you check something off your list from your checklist, make that comment, make that note next to it, just for you to remember, I did this, it's completed because, and the response to that. I think it's an easy way to not to have to write too much text, but at the same time, it's a reminder for you of how you close that element on your to-do list.
So when you're taking notes, are you handwriting them down on a pen and paper, or do you have an app that you use? Combination?
Oh God, that's such a relevant topic, at least for CRAs, because those who are a little bit more old school, myself included, we prefer paper. But what happens with papers? Same what happens with the delegation of authority log at the site. You lose these papers. You're constantly traveling. You have your flying backpack, your train luggage, you have your, when you go to the office bag, you don't always have these notebooks with you, and you need this information always to be with you. So I make an effort, a conscious effort, that I take all my notes with an app and choose the app, whatever app you want. If you need it to be compliant, yes, you can use OneNote from Microsoft. I know we all have been told that one is a compliant tool. But if you want to, be a little bit more brave, or you want to just try something else, I like to use Notion, for example, and just have sort of what I would have on paper, but electronic, that I can access it anytime. So I am a big fan nowadays, not 5 years ago, of taking all your notes electronically.
It's changed so much in 5 years.
It has.
It really has.
for good, thankfully.
Yeah. So if you're working like in a paper binder at the site, what are your thoughts on sticky notes? Hate them, love them, and why?
Sticky notes fly. I don't know how, but they always fly. It's like they have legs. They're designed with invisible legs, but I promise you they have legs.
You're cracking me up.
So whenever you see a sticky note written by your study coordinator or your PI, close your eyes. You can even just, they don't exist. They don't exist. Don't even read them. There's two aspects to it, right? Did you at the SIV, when completing your source identification log, say or mention that any of the source data could be a sticky note? If it's not considered a source data. So it's not an information that we can rely on, or that we can record, or that we can monitor, because it's not source data. And if you use it to just leave a note to your study coordinator as you did a good job, that's fantastic. But if you use it to say, this patient just reconsented, no, unfortunately, it is not. It is not a reliable or compliant means to record data.
Such a good point. Because 5 years ago, sticky notes, you'd see them a lot.
I know, and they fly.
Let's go to step 4. So step 4 discusses the process of scanning documents for the eTMF. What are some best practices for ensuring accurate and efficient document management during a monitoring visit?
It really depends on each study and each company. So what I would ask you back in here is, am I allowed to scan those documents with an app? Am I allowed to take a picture of those documents on my phone and then upload it from my phone to the eTMF? Or do I have to ask my site to give me access to some printer or scanner that they have somewhere in the basement so that I can scan the documents that I need for the eTMF? Because it's a nightmare. At least when I was a CRA in Spain, 9 out of my 10 sites would just say, forget about wanting to scan anything on our scanner, because we don't use it, or because exactly the opposite. everybody in the facility is sending documents to the scanner. So if you want to scan anything, you might need to wait by the scanner for 2 hours because there's
Mm-hmm.
documents in queue. So that's the point. I've seen CRAs who have these portable little scanners that they are provided by the sponsors, and the quality that comes out of them, hopefully nowadays, is better than it was 5 years ago when I was a CRA, because it wasn't very legible. So we would always have quality issues back to us saying, please provide me with a more legible version of that. But that's what we have. What I honestly would have done, and I did back in the days, was CRAs have a work phone. So these phones are very restricted. You almost don't even have your email app on your phones because CROs and pharmaceutical companies who try to be very compliant with the data, and they try to be aware and conscious of the data that we sometimes too much. But you can use these phones more easily, or you don't need to worry that much if you take a picture on your phone without sending it to any cloud-based software. And then from your phone, you can directly just send it to or share it on your computer. And then you have the PDF version of that and put it into the eTMF. That was my preferred version. That at least it saves some time because you can line up your paper documents at the site and just click, 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 go one by one and take pictures. And then I'll deal with it tomorrow when I'm at home and I need to turn it into a PDF. But yeah.
Yeah, I do not miss scanning documents, especially like at the sites when they would staple like
Oh,
a
God.
100-page CV, and then you're
Yeah.
pulling out the staples, and then the papers are getting stuck, and then it's scanning
Yep.
sideways.
Yep. Yep.
It
And
just
then you
makes
have
me,
to staple them back and you have to
yeah,
make sure that they're in order. And then you didn't, yeah.
yep. So, how do you recommend organizing documents and files to maintain clarity and prevent confusion, as you mentioned in step 5?
In our industry, we always say it depends, but it's reality. It really depends on what eTMF each study is using and how the eTMF is set up and designed. Because some eTMFs can be designed very clearly with a top-down approach from a very, let's say, big overview of the study, of the site, and then you go more into detail for the patient or for the more particular in detail documents. But as I would do with my email, I'll follow the same exact approach from top down. So I usually trying to have a bigger overview. I think it's also called this approach of having a God's eye type of view of where's my study at? What are the approvals of my study? At what stage my study is at? And then per site. For each of the sites, is this site recruiting patient? At what stage are we in? Did the patient complete the visit 4? Are all patients at visit 4? Is this site a little bit more forward or a little bit backwards, or do they need to catch up? So I would go level 1 study, level 2 site, and level 3. Then I would go to the site stuff, for example, or if I'm monitoring, I would go to patient per patient documentation. So I think that's my preferred approach, top down.
And you do that the same with your email. Did I hear that right?
Yes, yes.
You don't go from the bottom up.
Well, so that's the way I would file my emails. I do go from the bottom up so that I go to the newest emails and I check every email. Every single email that goes through my email inbox is seen. But then there is when the next step comes. What do I do with the emails? How do I tag them? How do I flag them? How do I flag them for follow-up or for a reference? Or if it's done, it just needs archiving. But am I allowed to archive? In my case, it was a no. So what I did was folders, and that's where the top down comes. I would have a folder of my emails for anything relevant to the study, and then to the site, and then particularly per patient, because you have a lot of emails referring to patients, and they come with the patient number in the email subject.
So you're pretty organized in your email. You've got it right down literally to the granular level. Like
I think the CRA job,
folders.
the CRA job makes you be organized. I don't think you have an option not to.
You're absolutely right. Let's get on to step 6. And that involves meeting with the investigator or study coordinator before leaving the site. So what are some key aspects that CRAs should address during this discussion? And how can they effectively communicate their findings?
Usually, these discussions are related or are a follow up of the monitoring visit itself, right? So, during the monitoring visit, if everything was smooth, if there was no findings, if there was no major issues, or if there's no clarifications that you need, usually it's just a wrap up or a conversation of, this is the state of the study that we're at. Do you have encountered any issues? Do you see any risks in the upcoming visits or in the patient visits? Yeah, it's basically just setting when the next monitoring visit will be. But in most of the cases, you will have doubts, you will have clarifications, you will have something that you found in the ECRF not to match the source data. So you need sort of a confirmation from your study coordinator or your investigator. Now, of course, sometimes it's simple things as if your source data is paper notes or the medical records sometimes are written, it's as simple as, can you tell me what this word means? Just because we know the doctor handwriting, sometimes it's not as legible as we would like it to be. So these discussions can vary a lot from, can you confirm so that I can put my tick on this data is monitored and we can close it, to I just encountered this protocol deviation, or I just encountered this serious breach. We need to report it. You need to be aware. Please note that there will be follow up after we report this. So it's an opportunity for the site and the CRA to be completely transparent of what the findings have been, if there's issues, and if there's no issues, also acknowledge your site for doing such a great job. And I think that's what fosters a good communication and a good relationship, because we CRA sometimes we only focus on those findings that we have, because that's what we're trained for, right? We're trained to spot the deviations, the issues. But we forget that when we have good sites and they've done a good job and they just recruited 9 patients and no deviations and all of them are on time, data is entered on time, no queries, data is clean. I mean, also, congratulations. I'm lucky to be the CRA of this site. So, in a nutshell, those are the conversations we have after a monitoring visit.
I love that. And you don't hear that very often, or it's not voiced enough when you actually do that positive reinforcement at the site, because that right there is going to build that relationship, like you said. And it's going to make it a lot easier to work with them than saying, you did this wrong, you did that wrong, and really pointing fingers and kind of beating them down, even though
Exactly.
that's your job to find mistakes. And
Exactly.
we're on the same team.
Hey, good, good. I like that because, and Nicole, sometimes CRAs are, I don't want to say that we're sometimes seen as a burden for the sites, but if we have the attitude of being a bad cop who comes on behalf of the sponsor to tell you off of what you did wrong, of course, we might not be super welcomed or warmly welcomed at the site. And we need to also stop a little bit that attitude that we sometimes have, because we're trained to do so. We're trained to represent the sponsor and make sure that the sites comply with what we've been trained that they should comply. So we're like this law that that sites have behind them and accompanying them during the trial. But maybe if we do it the other way around, through positive reinforcement and also through acknowledging that it's a hard job and we're in this together. We are a teamwork. No role is superior to the other one, and it is a team effort. So I think if we focus more on that, we're going to avoid and also prevent many issues down the road of the trial.
Exactly. And you always want your study coordinator to be like, oh, yay, this CRA is coming to my site today, instead of, oh, so and so is coming today.
Exactly. Why not? Exactly.
Can you share any memorable experiences or challenges you've encountered during monitoring visits and how you navigated them?
I will tell you one because that's the one that came to my mind, and it always comes to my mind when I think of a challenging moment as a CRA. And there's several, right? Because we do a lot of monitoring visits and we monitor for quite some time, and there's many occasions where you will have serious breaches, you will have big patient data, you will have backdating of informed consent forms, you will have even elements that are reaching almost the, is this legal what we've done? Or yes, we all have those challenges. But the most challenging situation that comes to my mind is one monitoring visit. I had to wake up at 3 a.m. because I had to be on site. I had to take a flight. It was super early. The sponsor was accompanying me on that visit because this sponsor specifically every 6 months wanted to come and see the data or see the, yes, it was a very hands-on sponsor, which is fantastic, but it puts a lot of pressure on your side. And that means a lot of pressure on you as well. And guess what? I was completely fine when I left home, but I got sick on the plane. My God. But sick. Like I had the biggest headache I had for a long time. Exhausted, headache, stomach sick, completely. Everything was just wrong. So I arrived on site, and of course, you are already tired because you woke up at 3. It's 9 a.m. You have a whole monitoring visit ahead of you with the extra effect of having the sponsor with you, and you're feeling crap. What do you do? So unfortunately, this might happen the day before, and every CRA, even though you have confirmed the monitoring visit, you absolutely should not go on site if you're not feeling well. Like it's your right to just take that day for yourself. You're not feeling well, get better, and then you will reschedule. Absolutely. But if you're already on site, you need to take a flight to go back home anyways. How do we solve this situation? And the fun part, and I think it was the first time I realized, I work in a hospital. So if anything happens to me, if I need any care, my colleagues are investigators. So I saw myself injected quickly with everything I needed. In half an hour, I was absolutely fine. I even had a nap on my way back on my flight home. So it was absolutely a reminder of there are some positive aspects of working in a hospital.
Oh my goodness, I'm speechless.
It can happen.
Wow. So you got treatment at the hospital and then you were on a flight back.
Yep.
Yeah. So did they fly out a backup CRA, or the sponsor was there and they just...
The sponsor's activity is sort of separate to yours. You are on site, and of course you both look at the data, and you will introduce the sponsor to the site's coordinator and so on. But then from there on is up to the sponsor what they want to look at or want to check. So what I did was basically try to, here we are. This is the person we have from the site. This is our site. Can you help me out, please? So I think I did my minimum job. I did all I could. Everyone was set. They were set up for success. You can do your work. Now I need to go.
Well, good. I'm glad you got the help that you needed. And like you said, like if anything's going to happen, I'm a top-notch hospital that's going to take good care of me.
Yeah.
So you were in good hands.
Absolutely.
Shifting gears a little bit,
we're
going to talk about SOPs, standard operating procedures. And how do you ensure compliance with SOPs and regulations while you're conducting monitoring visits, especially when it's regarding that documentation and data integrity?
Remember 2 questions ago when we were saying that CRAs are these, not an entity, but this role that needs to ensure that both sites and us, we comply with the regulation? Absolutely. It is a crucial part of our role. One of the main responsibilities that we have is to know the regulation, know the SOPs, both the sponsor SOP, the study SOP, but also the site's particular SOPs, because they also have their own standard operation procedures. But at the same time, while we try our best to ensure those are being met, we cannot turn into the bad cop, into that law attitude that we just, instead of coming on site to support our sites in their activities, in their patient care and in the operations of our study, we can't just focus on SOPs. Of course, we need to find a way to ensure that they're met. And to me, it's always been part of building a relationship that has its boundaries and that has very clear communication, and it has very clear and transparent collaboration way between the site and the CRA. So we know that this is the SOP and I expect you to comply with it because you agreed from the very beginning that you would. And at the same time, I am responsible to know the SOPs and to know the regulation. So I will do my part, which is knowing and being trained and being fully aware of what are the regulations that need to be met. So as long as we both do that, we are in agreement. Now, how do we make sure that happens during monitoring visits? it's very easy to not always ensure that it happens, because if you are super busy and you have 5 hours on site and you have 20 patients with data pending to be monitored, it's easy to not spot certain SOPs that are not being met, or we have a standard way to, for example, record how the informed consent process was for the patient, and it's easy to forget that, or it's easy to not check in the medical records that the full sentence as we need it to be, it's written in there. But that's why I think if the CRA is not overworked and it has a balanced capacity, within a balanced capacity, it will make it easier for the CRA to make sure that we're all working according to SOPs and regulation.
So let's say we got a clash in SOPs. All right. The site SOP on CVs says we don't require CVs to be signed and dated. You work for a company, your SOP says CV's got to be signed and dated. What are we doing?
It's a tough one, but it's a conversation to be had. Ideally, these type of differences in SOPs are spotted during the selection visits or the pre-selection visits, right? Because then it's once you've agreed to that and you've initiated your site and you've signed your agreements, everything needs to be established. And we shouldn't have these conversations once we started and we initiated the clinical trial. But if there is a clash, usually there is a conversation involved. There is a lot of back and forth, because there always is. Usually the CRA is always in the middle as well, because the CRA will be the channel of communication between the site and the sponsor. And then we will say, this is the SOP from the sponsor. Oh, site, this is the site's SOP. What do we do? Who bends? Who's more flexible? Can we, for this study, do this? No, we always do like this. Well, and then you go to a sponsor and say, we might want to do it this way, because if they do this SOP for all their studies and they only have one study, they do it differently, it might mean that they will forget about us and that they will operate in the way that they usually do anyways.
Mm-hmm.
So I think for all the cases I've had as a CRA, the sponsors were pretty flexible in that. And as long as it's according to GCPs and regulation and they comply with the information we need to have, I think most of the sponsors have agreed to the site's SOPs.
Very good. Yes. That's always been my experience too. We're following the most strictest rule that you can find. But odds are, if the site's been doing it and they're doing it all for all their studies, then let's rethink this SOP. Let's go back to the drawing board. So let's talk a little bit about the CRA Connect. Tell us about it, what it's all about.
Sure. Well, CRA Connect is an online community for CRAs. So we have a safe space that is an online space where we have international community of CRAs of all sorts of seniorities, from aspiring CRAs to very senior CRAs to even study managers. And what we're trying to do is to empower CRAs. And how do we do this? Well, we empower CRAs through knowledge, because we have courses. We have courses on skills, courses on GCP for CRAs. We take topics that are relevant to us, to CRAs, and we have a deep down discussion on those topics. Because what we found is that CRAs usually have an initial very strong training that is at the beginning. It can be provided by a master degree, a course, or a sponsor. And sometimes they have these programs of 2 weeks deep dive into the CRA role. But it is not enough for a CRA so that you feel that you have all the knowledge you need and you're confident in your activities. In 2 weeks, unfortunately, you cannot see all the monitoring visits that you will have to do, all the types of therapeutic areas, all the type of phases of clinical trials. So you always encounter yourself in situations that you've never been before.
Mm-hmm.
And the only way you find some knowledge and some insights into those new situations is when you surround yourself with a community that has been through that. And some CRAs will have seen those situations you have not, and you will have experienced some situations the other CRAs have not. So that's the CRA Connect space. Is courses, it's masterclasses that we do every month, is guest speakers that we have who bring knowledge as well to the community. And it's an open discussion space. So we have weekly events and we have sort of a forum in which all CRAs just, pop in there. Like, for example, this morning, my site lost the delegation of authority log. What do I do? So you can share those challenges that you have as a CRA with the CRA community.
I love that. So I've got two questions for you that I always usually end with. And the first one is, what is the best TMF tip or career advice that you've ever been given?
Can I tell you the best professional career that I had?
Mm-hmm.
So I would say for me, it was a trigger tip. And it was that sentence from the director of the master, the first master I told you at the beginning about, when that person told me, look into clinical trials. That was the best tip or the best, let's say, advice that I ever got in my professional career, because it brought me awareness of this niche and of this particular space that I never heard before. And I think many of us go through that. We've never heard about clinical trials when we were in university. So definitely that short sentence, that back then it didn't mean much, but it brought all the awareness of the existence of this space.
And lastly, what is your favorite TMF document and why?
Well, I am a CRA at heart still, right? So for me, my favorite document is still the site visit log. Because that's a document just for me. It's just for the CRA. You put your work in there, you put your monitoring visits, you put your pretty signature on it, you have your principal investigator sign it. It's like when you finish the degree and you hang your certificate, that's the site visit log.
Maria, where can everybody learn about you and what you do?
Well, we are very strong on LinkedIn. We have a big community of almost 15,000 people in our CRA Connect LinkedIn space. We are on Instagram. We started being on TikTok because we're trying to learn new tools, always trying to be curious and learning. But we're also on our website, and any of these means I'm more than happy to connect and keep in touch.
Amazing. I loved our conversation and I hope to talk to you soon.
Me too. Thank you for having me, Nicole. It's been a pleasure.